Evening, Dr. Atul Bhaskar. So today's speaker is Dr. Atul Bhaskar. I would like to introduce him. He's one of the prominent pediatric orthopedic surgeons in India. He's graduated from St. J.S. Medical College and KM Hospital with his MBBS and his residency. He further went on to train in the United Kingdom. He was on the Yorkshire Orthopedic Training Program and obtained his orthopedic fellowship and surgical fellowship. He also pursued his MCH from Liverpool and has completed a dedicated pediatric orthopedic fellowship at the world-renowned Hospital for Sick Children in Toronto. He has also received training in cerebral palsy management from Gillette's Children's Hospital, USA. He has a strong academic and research interest in pediatric orthopedics and has several international and national publications to his name. He's one of the few authors who has also published results of club feet treatment in India. So thank you for joining us, and over to you, sir.
One request, Dr. Bhaskar, thoda Hindi or English dono mila ke thoda boliyega. That's okay with you, yeah? Because my parents here, so jo ho sakta hai, yeah?
Can be as simple, but also if there's any query, questions later on, because some of the things may be technical, and I'll try and keep it bit more, simple. If there are any questions or anything to be asked, we can always clarify it later. I'll try and cover quickly a lot of conditions which we commonly see in practice and where parents seek consultation. And so I may miss out a few things. If anybody wants to know any further information, I'd be happy to answer them separately, or they can contact me on the email or the phone. So I'll start off with my talk. So I'll just share the screen. Let me know if it's visible. I think it's been disabled. Can you?
Rukaiya, can you allow her to share?
Yes,
yeah, I need to share the screen.
Yeah, she'll just give.
Yes, sir. You can now share.
So is the screen visible?
Yes, sir. It's just coming on. It's just coming. Yeah. Now we can see it.
Is it okay?
Yes, absolutely fine.
So the topic which is now is on the musculoskeletal disorders in children, early identification and early measures. And I can tell you from the outset, is usually the parents, the mother is the key person who can identify that problem. And I've always believed that if a mother has come with a child with the problem, then you must see very closely. And many times it gets missed, and I'll allude that with some examples. So typically, the common disorders we see in practice are the developmental problems, which almost form 40 to 50% of our practice, acquired disorders, metabolic problems, growing pains in children, and then I'll touch upon neuromuscular spine problems, which again are very common in practice. So you can see when you get a child, a newborn child, if you examine this child, typically we get reference from the pediatrician or the parents that are concerned about the foot shape. And very quickly we can make out from the shape of the foot what is the kind of problem the child has. And once we start to examine whether this foot is flexible or rigid, we can come to a diagnosis. Usually the parents, if the child is not being picked up by the pediatrician, when the child goes home, usually in the first week or 10 days, the parents will notice something abnormal in the child's feet, and they will come to us regarding obtaining a diagnosis. Similarly, you get these signs of asymmetry. For example, sometimes you will notice these kind of asymmetrical creases. So on the thigh, when you see these marks on the skin, or you see the neck, on this child is bent on the left side. Now see, this was noticed by the mother. Or when you see the knee, and you find that there is abnormal crease in the front, or this joint is very flexible. That means I can take this joint up in this direction. So these are early signs, and sometimes they can be picked up by the doctor in the clinic or during the vaccination, or usually the mother. When they will change the diaper, they will find there is something about this thigh which is not normal, and they will bring the child to the clinic. Sometimes it is very obvious. Sometimes many children have got severe problems. So a child like this, you can see there is the face is abnormal, the posture, or we say the shape of the child is abnormal, the joints are stiff. Hindi में जैसे बोलते joint जोड़ कड़क है. These children, you can see they will need extensive testing. They need to be seen by specialists who can diagnose the condition, what we call genetic doctor or geneticist. They will need sonography to see the kidney, the heart. We do a 2D echo, and then we do an X-ray. So these are early signs in a child which we must evaluate, because they could be having other problem beside the musculoskeletal problem. So these become important to see the child and must be investigated. Now, many times when the child is born, first time the child is born, many parents, they're not sure about the normal development. There are many misconceptions. You know, they have got advice from Dada, Dadi, Nana, Nani will say, usko malish karo, malish nahi karo, which oil is better, which is not good, you know, and then they like to wrap the baby up. So there are many different advice the parents get, and many times they get confused. And nowadays, especially with the nuclear families, there is no, joint family, then the parents are very unsure. And that is what causes a lot of the anxiety among the parents. So many times you remember when the child is inside the womb, there's a particular position of the child. And sometimes when the child is born outside, and many of them what is called a postural or positional problem. So they're not pathological. They are not abnormal, but just because the child is lying inside the womb, sometimes a twin pregnancy, then the space is less, they tend to have more problem, or the child is very big in size, weight is 3 kg, more than 3 kg, again, what is called packaging problem, then they will get some anomalies in the leg or the hand. Again, on day one, the walking pattern of a child keeps changing, and only by age 7, they get normal adult pattern gait. So when the toddler stands, he initially will have the knees are bent, then they have a broad base gait. You can see they have a wide space leg. Then they need some support to walk and run. And eventually by around 2.5 years, they start to walk. And then by 7 to 8 years, they get the adult pattern. So you see the child, most of the children initially will have a toe walking gait. And then later on, they will do what is called a heel strike gait. So normally children, they walk from toe to heel rather than heel to toe like adults. And toe walking in children is very common. So don't assume every child is going to walk and run the day he starts to stand. No, it is not possible. And that is why the nervous system, as it matures, the child's gait pattern will improve. So sometimes parents will come to us that child has not walked by 1 year, 18 months. It is normal. Up to 2 years is normal, provided there are no other signs of neurological deficit. So if the child is growing well, then walking can sometimes be achieved by age 2 years. So 2 साल तक बच्चा चलता है वो नॉर्मल है. 2 साल से पहले बच्चे पे ज़्यादा थेरेपी या इस पे फोकस नहीं करना चाहिए. Most children will walk by 2 years. So when parents come to us with different problems, so one of the common problems we see in practice is bow legs. जब घुटने bend होते हैं, and you can see the leg shape is curved inwards. Now this is very common. Not all these children, 4 children, have different diagnoses. They are not the same. And how do you know what child is abnormal and which is not, which is abnormal? So one must go in the history, and so you must have some idea about the presentation. When did it start? Whether the child was given a walker, whether he was heavy to walk with, what is the progression of deformity, whether it is getting better or worse, and then we do certain tests to know the cause of the deformity. Sometimes the child starts to walk early, like this girl, she got also short stature, and she had deformity in the leg. Also, you see the left hip is outside, so she had a left leg shortening, and she was very short for her age. So these are what is called developmental dysplasias or skeletal dysplasia, which were the child, बच्चे की height कम होने की वजह से ये बच्चे थोड़ा लेट चलते हैं और उनके पैरों में या हड्डियों का size थोड़ा कम होता है. And on the X-ray you can see there is also a hip dislocation. Again, one must look at the child in complete. So you can see this child has got knock knees, he's got protuberant abdomen, his stomach is outside, You can see the brothers and sisters, one leg is straight, this child is bow legs. So this child, I know when this boy grows up, he will become normal because this is a physiological problem. You see the eyes, you can see the blue tinge in the sclera, which is suggestive of either a collagen disorder or with ligament laxity. These children tend to have more knock knees. And also look at the other child. So you can see this child has got knock knees and this child has got bow legs. But they have a condition called X-linked rickets, which is a genetic condition. So if a child comes after age 7, he will get knock knees. If he comes below 3 years, they get bow legs. And I'll come to this why it happens. Again, look at the father also. This father is short. The daughter is short. So the father actually came with the daughter that my daughter's height is not increasing. And then we did the X-ray and we found the child has got bow legs. And when we did the blood levels, this child had what is called resistant rickets. That means they don't respond to vitamin D, but they need phosphorus. Now the father was not sure whether the daughter had the same condition, but when I saw the father, I said, even your height is short. And we did his test as well. So both of them had the same problem. So examine the child, the family. If they have a sibling, examine the sibling, and you can get a lot of information just by looking at the child and the parents. Sometimes this child had progressive shortening, and this is commonly seen in condition what is called achondroplasia or short stature dwarfs. You know, पहले ज़माने में ये बच्चे इनको circus में लेते थे, but they have a normal life. They are very intelligent, and one should not dismiss them just because the height is small. And so this is what is called achondroplasia. And many times in the past we would give them vitamin D therapy, but they don't need vitamin D. Nowadays we give them growth hormone, and you can get some increase in height. There's also there's a gene defect which is now well established, but unfortunately there is no treatment. So this is a condition which is seen at 9 months, and by the time they're 3 or 4 years of age, it is well established. So the child I showed you earlier, why the deformity improves. You see this child has got bow legs, 3 years straight. And this is because this is the normal pattern of leg growth in a child. All children who are born, they are born with bow legs. That means their legs are inwards. And as they grow, they will become straight, and then they will go into knock knee pattern. That is why if they get a deformity or rickets below 3 years, they will continue to get bow legs. If they get rickets or vitamin D deficiency after 3 years, they will go into knock knees. Sometimes they can get rickets between 3 to 7 years, and then they will get what is called a windswept knee, which I'll show you an example. This is a child who had bow legs, but this child is also very overweight, and there's something called Brown's disease, where there is defect of the growth on the inner side of the bone. So parents were saying this child's leg is not improving despite giving vitamin D3. When we did the X-ray, he had what is called early Brown's disease. So this is the only condition which is seen in children between 2 to 4, where the bow leg doesn't improve. Similar girl, you can see this girl was 2 years old, her weight was 40 kg. And the X-ray showed this finding on the inner part of the leg. This is a lower bone called the tibia, and this girl underwent a surgery. So this is what is called a Brown's disease, and this again should not be missed. And the parents will complain that the leg is limping, and despite giving vitamin D3, this doesn't improve. So Brown's disease should not be missed, because the sooner we treat them, the better result we get. Sometimes you get a problem only on one side. If you have one side problem, that means there is either some underlying infection or injury. You cannot get one side deformity due to developmental problem. Developmental problems are always on both sides. So if the one side problem, this child had an X-ray. Mother didn't remember when the child was small. He had some infection. They told us later on, and the X-ray showed there is bone destruction and there is deformity in the leg. I already discussed this graph, and you can see why below 3 years they are bow-legged. They will go into knock knee pattern. So this is very common, and this is normal development in a child. Now if you take a rickets between 3 to 7 years, you see this child has got one leg is straight, and one leg is bent. And you can see the signs of rickets. You can see the bone is not normal. There is this pattern which is seen in rickets X-ray where there is a haziness of the growth plate, and this is a classical sign of rickets. And you can see the leg is shaped. So this is what is called a windswept deformity, when there is deformity between 3 to 7 years during the transition phase. And many times parents will come like this: the child is having crooked legs, and when we take the X-ray, it shows signs of rickets. Again, we can see them in older children as well. This 10-year-old child, again a deformity, one leg more than the other. You see the vitamin, the alkaline phosphate is very high, more than 3000. Normally it should be 800. And you can see signs of rickets again, like I said, very, very hazy growth plate. X-ray is not showing the classical white line. There's multiple haziness here, and there's very wide growth plate. So these are signs of rickets. And vitamin D level was 12. And again, very high alkaline phosphatase. So these are signs of rickets. And sometimes this child actually came with a fracture. He fell down. You can see the fracture in the bone because of very low vitamin D. And then when we gave the vitamin D, after 6 months, the bone became completely normal. So you can see the classical pattern, the deficiency in the bone, both bone fracture, and healing signs after 6 months. Now, this is a video I'll just show of this child. Now, see how she gets up. And the mother was really concerned when she, I think, was 11 years old. And see how she struggles to get up. So she struggles. And the mother is saying she cannot climb steps. She having difficulty in walking. And this is very commonly I've seen now in the pandemic. Children have become recumbent because of the lack of school, lack of activities, no vitamin D3 therapy, no sunlight exposure. And this child had vitamin D3 deficiency. And this was seen by the neurologist. They thought it's something with muscles. But when we gave vitamin D3, she completely recovered. So this is not unusual in the older child to get vitamin D deficiency. And you can see what happens in the older children. Because they are sitting at home, having a poor diet. Now this child had pain in the hip joint, and the vitamin D was only less than 4. So, typically with children who vegetarian diet, overweight, they tend to get a lot of hip pain. And when we do vitamin D, it's very low vitamin D. And this child, you see, he was 80 kg of weight. And there's a slip in the bone. Sorry. So this child had a pain in the hip joint, and you can see what has happened. The bone has slipped. This is called a slip bone. And this slip occurs because he's overweight and low vitamin D3. So child came with a limp. The mother was concerned, why is limping? We did the X-ray, we found there's a slip and vitamin D was less than 4. And again, he needed a surgery. So these are early signs. If a child cannot get up from the chair easily, he's having difficulty in climbing steps, he's limping, you must know vitamin D3 level. These are very early signs of deficiency, even in older children. Children who are 11 and 12 and 13, even they can get deficiency, despite sometimes having a good diet, because they've not been exposed to sunlight and lack of physical activity. So we used to use these sprints very earlier on in practice, but now we don't use this. It is not easy to put, but just for completion, I've shown them. Some parents want some sprints for the child, so I give them for bow legs, but it is not very useful. The opposite of bow legs is knock knees. Now, the knock knees is what, when the leg is going apart. When you can see this distance between the feet is very high. Normally, it should be less than 12 centimeters. So if it is more than 12 centimeters between the leg, and you can see we measure the distance. This is called knock knees or genu-valgum. So these children again can have vitamin D problem. They can have tissue laxity. And this girl, you can see, had almost 25 centimeters of distance. So this is a very severe. And when she stands, you can see that the knee is overlapping. So this deformity again was because of vitamin D deficiency. Parents came from a village. They didn't take any treatment, and she became very, very severe when they came to us. Like this child who was 9 years of age. Again, you can see knock knees. He had short stature. Vitamin D3 was normal, but his phosphorus was low. And now what we do is, for treatment, we don't put them in plasters. We do what is called this operation, which is done from a small incision under X-ray control. And we put these small plates And as the child grows, you can see the deformity will correct. This half will keep growing. So where we put the plate, this half will not grow. This part of the bone will not grow. And as the child grows, the bone becomes straight. And you can see the same child at 20 months, the bone has become completely straight by putting these plates. So this is what is called guided growth operation. इसमें हम बोन की दिशा को चेंज करते हैं. ये क्लिप लगाने से, ये स्पेशल क्लिप है, टाइटेनियम क्लिप है, जो हम बोन में लगाते हैं और इसमें बोन का डायरेक्शन चेंज करते हैं. वी डोंट कट द बोन, बोन को हम कट नहीं करते. धीरे धीरे जैसे बच्चे की हाइट बढ़ती है, बच्चे के पैर सीधे होते हैं. और ये आजकल बहुत कॉमन ऑपरेशन है. दिस इज अ वेरी कॉमन टेक्निक टू डू, very safe for the child. They can do the normal activities, they can go to school, and as he grows taller, the deformity will correct. So this can only be done in a growing child. You cannot do when the growth is finished. So you can see the same technique. Knock knees here, बच्चे के पैर में knock knees है. दोनों you put these small clips and the leg becomes straight. So this technique is very commonly done nowadays for deformity in the legs. Like in this girl, we did it again. You can see the scar and the leg is straight. So it takes almost 1.5 or 2 years to make the leg straight. Now coming to one more common condition, flat feet, when there is no arch. Now this is very common in the newborn. The arch develops between 4 to 7 years because in newborn there is a lot of baby fat which covers the arch and hence you can't see it. But in my practice, I see a lot of children with flat feet, and I can tell you the common causes which I see. Many children are using nowadays this Crocs footwear. Sometimes my parents give them shoes very early, closed shoes, and sometimes the parents give them a walker before 2 years so that the child can start walking. And also these surfaces now when the children are playing, a lot of them are artificial surfaces like granite, marble, turf, where there is not much foot movement in terms of flexibility. So I see a lot of flat foot children coming now. When I inquire in the history, either they are wearing this kind of improper footwear, or very early the parents give them shoes. Before 2 years, they're given closed shoes, and they tend to get flat feet. And you can see an example. Now you must know whether this feet is flexible or rigid. So best thing is to make them stand on the toes. And you can see the arch formation, this is flexible. Normally the children have no pain, but if they have pain in the feet, then you must do x-rays because they can have many other causes of flat feet. Sometimes they can have bone deformities. They can have a joint problem which can cause flat feet. So X-ray is only done when the child has pain. Many of these children with flat feet also have got hyperlaxity. उनके जोड़ों बहुत लूज होते हैं. जैसे इनका जॉइंट आप देखेंगे तो अंगूठा पीछे की तरफ मोड़ सकते हैं, उनका पैर भी पीछे की तरफ मोड़ सकते हैं. So their tissues are very lax. So these children are called hyperlax or loose joint, and they tend to have a lot of flat feet. No treatment is required for flat feet. Sometimes I give them insoles. They are not harmful. And many people, normal people also have flat feet. So most important thing is to give them physiotherapy or exercises to improve the foot shape. But remember one thing, many of them are genetic. The foot shape will not change much. If they've got a congenital problem, that means parents have flat feet and child also has flat feet. So we tell them to avoid sitting like this. They should not sit in this position. I give them these special insoles if there is a lot of shoe wear. If there is a lot of problem in the shoe or they get pain, then we give them these custom silicone arches. Now, if they're very severe flat feet, then nowadays we do the special surgery. We put a special screw in the joint. So the child is like this and then they become straight. And this is what is called the hip cured implant. This is a silicone implant, a titanium implant which you put in the flat feet. But this is not done very commonly. It is done only in children more than 9 years. And they're painful flat feet. So we don't do it routinely for children who have got no pain. So we try and focus on the arch muscles, the strengthening. You make them walk bare feet. You make them walk on sand or grass. You make them hold a ball with the feet. Simple exercises to improve the arch strength. Other common symptom we see in children when parents come to us are growing pains. Many children get growing pains, which is common below 4 years of age. Normally pain in the night. So दिन में बच्चा सब खेलेगा कूदेगा और रात में parents बोलेंगे नहीं बच्चे के पैर में दर्द हो रही है, बच्चा रात में सो नहीं रहा है. So this kind of night pain is very common, which is part of the growing pains. Sometimes they may have joint swelling, and the common treatment we advise to parents is that muscle stretches and some warm massage. So you can put some hot water massage. Many of the children are very, very active. So as they increase activity, by the third or fourth year, they keep stretching the joints in the day. So night time they will get the pain. And there are many parts of pain in the child. There are many areas of pain. You can get pain from the cartilage. You can get pain from the growth plate. You can get pain from the joint. So in children, there are many areas which can cause the bone pain, and it can be seen mainly around the knee joint. So रात को बच्चा बोलेगा मेरा घुटने दर्द हो रहे. This is very common, and he will point to both the knees. दोनों घुटने में दर्द होएगा. And that is a common presentation of growing pains. Again, during the day, they are very active. They will play, and when they come in the night, they will complain of pain. Again, very common cause of pain is around the heel. Mother will say the child is having heel pain in the night, and this is because in the day they are playing a lot of sports, and then they have this plate. All you need to do is do stretches, do calf stretches every day, for 6 weeks, and they get better. Very rarely we need to give them crocin, or we need to give them any special medicines. Again, one must make sure they don't get any other conditions. So you must make sure they don't have any rickets, or they don't have any other disease. Sometimes children will have some metabolic bone condition, and they can present with fracture. So those ones should not be missed if they get early fractures in children. Again, heel pain, like I said, is very common in boys, and when you do X-ray, they get this X-ray will show this fragmentation of the growth plate. You see the X-ray here. This is the growth plate, and you can see some fragmentation. And they pain in the knee. This is the part in the knee. This is the growing part of the knee where the bone grows, and this is called Osgood disease. So parents complain that child plays football, comes back, his knee is paining in the front, and this is very common because of the pull of the muscle. And sometimes, very rarely, I put them in a plaster. Normally I give them this kind of brace. You can see the brown color brace to give them some rest. But this child was very, very severe. He was getting recurrent pain, so I put him in a plaster. So growing pain coming from the cartilage, pain coming from the growth areas are very common in the active phase of life during 8 to 12 years. Where mother will complain that child is having night pain or pain after activity, but no other time the child gets pain. So that is how you differentiate between other causes of pain like TB or infection, where they will have fever and other signs of pain also. Now, this was an interesting child. This child had bilateral femur fractures. You can see the bone is broken. There's a fracture here in the thigh bone. So the mother, the grandmother was blaming the mother that you are not looking after the baby. This child was 2 years old, and the child had 2 fractures. And you can see the bend in the bone. Now, this child has got what is called fragile bone disease or osteogenesis imperfecta. Now, sometimes these children, when they're very small, they have this special triangle face. They have blue color, like blue tinge, you can see here. They may have poor teeth. They may have the teeth may fall down very early. They may have a wide chest and small height. And sometimes these children can be seen very early if they have this blue sclera. And you must then examine the child whether they got signs of fragile bone disease. They sometimes will get a fracture with a small injury. So they will just slip and they'll fall and they'll break the bone. So it's not a very difficult injury, not a very hard injury, but they will get fracture. So this is what is called osteogenesis imperfecta. There are many types. There are only 18 types now. So all these children who got fragile bone disease, we do some testing by making sure we know what type it is, and based on that we will do the treatment. For example, this child was almost 9 years of age when he came. You can see the deformity in the bone. दोनों thigh bone में fracture था, and he had severe deformity. So decision was when to do the operation for these children, when to make the bone straight. So nowadays we give them the medicine first. We give them the drug called Paediatric. Every 4 or 5 months we give them at least twice or thrice a year. Now this medicine will make the bone strong. It doesn't cure the disease, but it only will make the bone strong. And then we can do the operation after we give a few cycles of this drug. So normally the girl I showed you earlier, we did this rod in both the thighs, and then she was able to stand. So she was not standing because she was getting multiple fractures. And this was classical fragile bone disease. And then the mother could make the child stand with support. The other child I showed you, sometimes he was very severe deformity. So we used to do this kind of open surgery, what is called the shish kebab surgery, looks like a kebab. So this was described in 60s about shish kebab surgery. You remove the bone, put the rod inside, and you can see the rod is here, the child is standing. So we do this very commonly now to prevent fractures. We put these rods inside, and nowadays we have special rods also, which is called telescopic nail. So this child also you can see, they came from a village, severe deformity, mother didn't take any treatment because they could not afford. And then we did the operation, and you can see the bones are straight. We use these special rods, which is called the telescopic nail. So these nails they're expensive. They have this two ends of the nail. So one nail goes inside here, one goes here, and they will telescope. As the child grows, the nail grows. Of course, they also have the problems, but nowadays we try and use these nails if the parents can afford it. Now coming to the congenital deformities which we see in practice, the common thing I see in practice is the trigger thumb, where the mother will say that ये बच्चे का अंगूठा नहीं खुलता है, वो ऐसे lock है. The thumb is locked, and many times this is picked up as early as 9 months. Many times the pediatrician will say, don't worry, this will get better. So we only teach the mother, we tell them to stretch the thumb and do gentle massage. So many times they will correct by 18 months. But if they persist beyond 2 years, then sometimes I would recommend a surgery. And you can see what happened. There's a swelling here, right at the base. And this joint is bent. So angute mein yahan pe bend hai, and there's a swelling right at the base of the thumb. So this thumb has got a swelling here at the base, and you can see by mark. And then you should massage this slowly. If you massage it, sometimes the swelling will settle down and the thumb will open up. So I normally wait up to 2 years, 2.5 years, and sometimes they can have it on both sides. So this is a very common condition in practice. It is called trigger thumb. And after the operation, you will see the thumb will completely open up. So it's a very small surgery, and we can release the tendon and they get better. Clubfoot, again, very common condition in practice. Almost I see about 5 to 6 clubfoot every month. And new children with clubfoot. I don't know why it's become so common, but you can have many types. We can have a mild type, you can have a severe type of foot deformity where the foot is completely bent inwards. This is a very severe type. But whether it is mild or severe, the treatment is now standard. We put them in plasters. So we give plaster as soon as the child is born. They don't need any anesthesia. We change the plasters every week. And then by 4 to 5 plasters, the deformity gets corrected. Very rarely they will need a surgery, especially if we cannot get the foot straight in the end. And the last plaster is kept for 4 weeks. So this is a very common technique for treating clubfoot. And it is called Ponseti technique. Ponseti is the person who described this. And so we start with plaster. You can see this is a deformity at birth. This is the child. We did a small surgery. We do what is called a tenotomy. I'll show you. This is the plaster. And then after the correction, the feet are completely straight. And you see what happens when you correct by plaster. Only this deformity remains, where the foot is pointing downwards. You make a small cut here in the crease. This crease is very tight. And then you put the final plaster. And this is the area where you do the cut. So no stitch is required. This is done under small anesthesia. And then we do the plaster. And then the foot is straight. So this is how we get the correction. So many times parents are very concerned कि बच्चे के पैर टेढ़े हैं, इसको बड़ा ऑपरेशन लगेगा, इसको कैसे करेंगे. So we tell parents that if you follow the treatment properly, many deformity in children can be corrected by plasters only. You don't need very big surgeries early on. And then we give them, you can see the mark of the surgery, we give them splints. Very rarely we do these very big surgeries in children nowadays. So even if they come late, if they come from a village sometime, we have no choice but to do the surgery. So then we plan procedure after age 2 or 3 years. You can see the scar of the surgery. But these feet are stiff. They're always a bit stiff. Hip dislocation is very common in children now. I told you earlier on, this mother came to me and told me the child is limping. And nobody examined this child. He came with a limp and his leg was short. And I told the mother, when did you notice this? She said, "नहीं, बच्चे का 9 महीने से पैर छोटा दिखता है." But doctor साहब बोलते बच्चे ये normal ऐसे चलता है. We did the X-ray and we find what happened. You see, this ball is here, this ball is outside. This ball should be here. This is called hip dislocation. Now this is because this is painless. Many doctors, they ignore it. Because when they go to pediatrician, he will give a vaccine. They have no time to examine the child. And if only you bend the leg like this, you will find इसकी height नीचे और ये ऊपर है. So ये पैर छोटा है, but छोटा नहीं है. इसका ball बाहर है. This is called hip dislocation. And this is very common. Again, I showed you earlier that slide. you can see this crease. When you find like this abnormal crease in a child or leg like this child, there is some problem in it. And you must do the X-ray. Of course, in the doctors will do some tests, but one must do the X-ray and find out. So I made this small chart for the doctors. This is called hip a minute. In 1 minute, you can examine whether this child has got hip dislocation. You spread the legs. Wherever the leg spread is less, like this side, if you just bend the leg like this, if you find that movement is not symmetrical, your dono pairs same nahi dikhte, when you change the diaper, then you know there's a problem in the hip joint. And when you bend the leg, you can see the leg is at a shorter level. So these are small signs to alert. You must identify the signs very early. And sometimes the mother is the best doctor, I tell you. They will know and they pick up signs very early, and we must listen to the mother. Of course, the treatment is very easy. If they come before 6 months, we give them this special splint and we can reduce the hip. If they come older on, they will need surgery. If they come between 6 to 18 months, they will need anesthesia, they will need close reduction, they need a small surgery, and then they will need a plaster. So this child was older. We put a dye in the hip joint to confirm that the hip is in the position. And you can see we put a plaster and the joint is located. This is the X-ray before the plaster. This is the X-ray afterwards. So the hip, this is a bigger procedure. So if you can identify the problem before 6 months, then they don't need to go through this big treatment. Of course, older children will need a big surgery. Torticollis, again, very common condition I see in practice. You can see this child has got tight muscle here. He's keeping a neck slightly bent on the left side. Again, if you go in the history, there could be a history of difficult labor. There could be a cord around the neck. गर्दन के उधर जो बच्चे की कॉर्ड होती है, वो कभी कॉर्ड हो सकती है, गर्दन में सूजन हो सकती है, बचपन की बर्थ के बाद, या बच्चे का स्कल में फ्लैट हो सकता है, उसको बोलते हैं प्लेजियोकेफेली. So these are early signs of torticollis. Torticollis means neck tilt. I'll show you the example. For example, this child, you can see the neck is tilted, and this is how we do the stretching for the torticollis. So the neck should be stretched to the opposite side. So this child has got torticollis on the left side. So you bend the neck on the right side. So if there is contracture here, you hold the shoulder here and you tilt the head. Same thing for this child. You can see you bend the neck on this side but hold the shoulder. This is an important exercise to start very early on. If you find the child is keeping the neck in one position, you must start early exercise. And mother is the best physiotherapist, because such a small child will not cooperate. So once they are taught by the therapist, this will be at home in 20 minutes a day. You stretch the neck, like I'm showing you here. So this child, you can see, he's got right side torticollis. You bend the neck on the left side, but rotate on the same side. You rotate on the same side, but bend on the opposite side. Okay, so this is very important exercise for torticollis. So right side rotation, left side flexion. If you do it every day, you'll find the child deformity will improve. Only thing, if they don't improve by age 4 years, we do the surgery. Like this girl, we did the surgery, and this is the collar we give after surgery. And you can see this is the exercise she does after 6 weeks of the operation. So many times they will not improve, and then you must do the operation. It's a very small operation, and it's very rewarding if they come early, and they do very well. Sometimes we give them a special collar, like a brace if they are very tight. So you see, and sometimes we give them a collar like this. So this is required after the surgery, because otherwise they will just go back. And it's a very simple surgery, but they require good bracing and physiotherapy after the procedure. And normally I teach to the parents, because they can do it, at home 3 or 4 times a day rather than going to the therapist once a day. It needs more frequency of exercises, and that is the crux of the treatment. More therapy, more motion of the neck, the better results. Coming to last few slides, every parent must see the child's back at least once in 4 months. So बच्चों को जब आप स्नान देते हो 4 साल के बाद बच्चे का कमर हमेशा देखना चाहिए. Full spine must be seen, because sometimes they can get deformity, especially girls. Scoliosis is very common, so mother must see the child's back, and sometimes you can get early signs of twist in the spine called scoliosis. And if they are early signs, you can treat them in a brace. Otherwise, they will end up needing surgery. But this girl, you can see there is scoliosis deformity on the right side. And we taught the mother some exercises, how to do. So essentially, you make the child bend forward. You can do the bending on the right side. And they must do this exercise every day. So this you can see the therapy program which we teach the parents. They go to a physiotherapist because they need some special exercises for this, depending on where the curve is. So with a high level, you can have a double curve like a S curve, you can have a triple curve. So where the curve is, depend on that. You have to plan the physiotherapy program. You have to manipulate the spine. These are simple things, but it must be done repeatedly, at least for 12 months to 18 months. And sometimes we give them a brace to wear. So this can be done, at home under supervision of a good therapist. Sometimes the curve will not improve. They become stiff. This is not in every case. Sometimes the curve is very difficult, very strong curve. We do the rodding. These are big surgeries, so we don't take it very lightly. We give first all chance for physiotherapy and bracing. Then only we go ahead with this kind of surgery. Sometimes you can get a slip of the bone. This child had a slip of the bone. We were limping like this. The mother came and told this child is having a lot of pain in the leg, but the pain was coming from the back. So leg pain in the child can come from the back. One should be aware of that. Also, other causes of back pain are the myelomeningocele, which is not seen many more because all ladies during pregnancy now take folic acid. So during the pregnancy, once the mother knows she is pregnant, she must take folic acid to prevent what is called neural tube defect. And this is now very rarely seen nowadays in practice, at least in the Western country. You don't see MMC that commonly. It is still common in India because in the rural areas, they don't get the folic acid supplement. So in the child, any mark on the back, any scar on the midline, you must investigate because they can have what is called a spinal cord problem. So any child which has got a sign on the back, अगर बच्चे के कमर में कोई भी दाग है, कमर के बीच में, उसमें हमेशा एक्सरे करना चाहिए, MRI स्कैन करना चाहिए because they can have problem in the spinal cord. TB spine again is very common in our country. So any child having back pain more than 3 weeks, difficulty in walking, night pain, mild fever, weight loss, you must always think of TB spine and do an X-ray or MRI scan. So any child who, if the mother tells me is having back pain more than 3 weeks, not getting better with medicine, you must always investigate because TB spine, TB in this country is very, very common, even in affluent class. So don't miss a TB spine. So back pain in the child, don't ignore. Coming to some common conditions like for neuromuscular CP, again, from the birth history, one can identify which child will have a problem. So preterm delivery, high risk factor, jaundice, these are all risk factors for cerebral palsy. We know the problem because of the loss of motor control, poor balance, child is not able to play, so muscles get tight. There are many types of CP. In practice, we see common is diplegia. There are different problems in walking. So some children are walking on the toes, some are walking with scissoring pattern. Some children, as they get older, have got muscle contracture, and many of them, they cannot walk. They sometimes only need a wheelchair. And now we got a very good gait lab in our in Mumbai, in Mahim. So where we do a complete evaluation of the child, we do the hand evaluation, we do the leg evaluation. This is a Xavier gait lab in Mahim. And many of the children will have well, and then we get these graphs in the child. So we look at before, and every child today we send for evaluation today. So whether they can do a 2D evaluation or 3D evaluation, so we do a thorough evaluation before we embark on the treatment. So this is now a common tool we have. We have been running the lab for the last 2 years in Mahim. It's a cerebral palsy lab called the Motion Lab. And so, it is completely free for poor children. It's been donated to us by an NGO, so we can use this at our will. Now, of course, these children with cerebral palsy can have joint problems. They can have deformities. We measure the muscle tone by various scales. And nowadays, we don't go directly with surgery. We start with rehab. We give them Botox. And, this is a treatment which is very commonly done now. Low Botox therapy. Below 7 years of age, we prefer to give Botox. We don't do any surgery unless the child is very, very tight. And we give Botox injection under the ultrasound control. This is the calf injection. This is the hamstring injection you can give to release the tightness. Sometimes we use the muscle stimulator to be in the exact part, especially in the deep muscles. We use this special machine. And you can see the sites of injection in a child. And many times, like this child who had CP, he was walking like this. And then after 1 year again, you can maintain the correction is maintained very well. Example, we just see which muscle is tight before we plan the surgery. So sometimes we have to do operation, like in this child was very, very tight. And then we give them the splints so that they maintain the correction for the long run. Foot surgery again is very common in these children because there are many times they have deformities, they get fracture in the leg or they get callosities. So just to make the foot straight, so they can put weight on the leg. Like this girl was walking with a walker, but her foot was deformed. Her mother was saying she's getting a lot of pain in the feet and she can't stand straight. So we did the foot surgery and got the foot straight. In children who don't, you must always see the hip joint because the hip can dislocate. So any child who is not walking in CP, we always do an X-ray of the hip joint every 6 months after age 2. So or if you find the child you cannot split the leg. So when the mother says, I cannot change the diaper, the legs are very tight. You can see this position, X-ray, and this child had bilateral hip dislocation. So this should not be missed. So once this when the hip is dislocated, they will start needing big surgery. So it's better to avoid this position. If a child is walking like this, or they have this kind of posture, we give them a Botox injection and we give them a brace to get the leg straight so that we can prevent a hip dislocation. Some cause of limp in the child. So I'll give you a couple of examples. This child was a toe walker. So this child was walking on the toes, which, like I said, is a common pattern of walking in a child. This child was not CP, but idiopathic toe walking. We just gave the child some splints and they got better. One example I want to show you here. This child was walking with the foot outside. Mother was complaining that my child walks like this. Or this is not normal. One side walking is not normal. And my child had no history of fever, no infection. And then we did the X-ray, was normal also. And then we saw the child's back. We saw that the leg appears a bit thinner. And you see in the midline, there's a scar. So always in the child, if there's any mark on the back, बच्चे के कमर में अगर कोई भी दाग होए या छोटा खड्डा होए हमेशा बच्चे का स्पाइन दिखना चाहिए. So this child had a tethered cord. Spinal cord में there was a problem, and then we did MRI scan, and they had what is called a tethered cord. The cord was very low, and this child needed a surgery. So very important to see midline of the back of any child. Every child must be seen from the back and the front. This had different how he walks. They came from a village. Mother was saying this child cannot stand properly when he sits from the floor. He gets up with support, and you can see how he gets up. So this is not normal. This child had what is called DMD, muscle dystrophy. We did a gene test, and we did a blood test. His values are very, very high. This is one condition which should not be missed. Is a DMD. Of course, other causes of limb can be Perthes. This child had we did an X-ray Perthes disease. This child had a slip of the femur. Older child. So limping in a child, almost do an X-ray. The limp is going beyond 3 weeks. So any child having limp beyond 3 weeks, you must investigate. So this child had a slip, like I showed earlier. You can see the ball is slipping, and then they need surgery. So any child having pain beyond 3 weeks, always do X-rays. So I think I've covered a lot of the things in this talk. I may have missed out a few. You can always go on the website and refer some of the topics which are covered. If anybody has any question, they are most welcome to give me a call, or we can discuss on the mail. But I tried and covered most things briefly. I hope the message is clear that it is important that things are picked up early. What I call a stitch in time. That means if things are picked up early, whether they are developmental, whether they are congenital, whether they are acquired, whether they are post-injury, post-infection in children, there's a lot of potential for remodeling. And today we have got therapy, we have splints, we have a very good rehab departments in most hospitals. So we must take advantage of the rehab setup. We must run the modern treatment. And I'm sure we can do much more what was done available, 20 years ago when I started my practice. So things have evolved a lot now with technology. So I thank Mrs. Shilpa Srivastav and Mrs. Sood for giving me this opportunity. And if parents have any questions, they can ask me. Thank you very much.
Thank you very much for this talk, sir. And there is.
I'll just end my talk here. Thanks.
Yeah. Hello. Yes, sir. Am I audible?
Yes, yes.
Okay, okay. So there is a question in the chat, sir.
Yes.
Swarnika's mom has asked that she wants to ask regarding her daughter who does not move and her muscles are not toned and her foot is swollen and she has the same hole. I think the scleral dimpling, I think that she is talking about.
How old is the girl? How old is the child?
Hello, sir. This is Swarnika's mom. She is 11 years old, sir.
11 years old, and she's got this. She's not moving her muscles.
No, she moves her muscles. Means she cannot walk, and the foot part means her feet swollen. The feet part is always swollen.
Both the feet or one feet?
Both the feet, sir.
And she also has got history of delayed milestone. Does she have delayed walking or delayed sitting?
Yeah, yes, sir. Yes, sir. She cannot walk still. She is in wheelchair, and she's in wheelchair. But we need to move her, according to us. She can turn and do all those things.
Correct.
But her lower part is very weak.
Correct. So now see I mean, I need to obviously examine the child, but there are a lot of issues, the tone can be either increased tone or low tone. So if the problem is in the brain level, that means it is above the cervical spine. Gardan Kubar, if it's a problem, that means it is got high tone. If
Yeah, she has a problem in this part also. Means she holded her head very late. Still, she has that problem. She always puts her neck down like this.
Correct. So is she having what is called spinal muscle atrophy? Because there are many conditions which can cause neck weakness. So one of the condition what we call is called spinal muscle atrophy. There are different types of it. There are 3 types. Of course, the one which are if she is 11, it could be she has a mild type. Now, females usually have a different type of muscle disorder compared to boys. The boys is called Duchenne's, which is very, very progressive. But in girls, they can have what is called Becker's dystrophy, or they can have SMA. Now, if the child is not, one of the principle in walking is, if a child has not walked by 8 years, that means they will always need some support. And that is because the brain development, the central nervous system centers for walking, develop by 8 years. तो अगर बच्चा 8 साल से पहले अगर नहीं चलता है, तो उसके 8 साल के बाद बच्चे को हमेशा कोई सपोर्ट लगेगा. Either he will need a wheelchair, he will need a walker, he will need crutches, or he will need orthosis. Because walking जो होता है, walking का जो सेंटर है, वो 8 साल तक डेवलप हो जाता है. अभी काफी कारण होते हैं, जैसे बच्चों को अगर बचपन में पोलियो हो जाए, या they have SMA जो बीमारी है, or they have got Guillain-Barré syndrome, or they have got transverse myelitis. अगर they have viral infection बचपन में, जिसमें बच्चे के nerve के cell damage हो जाए, then there is no chance they will walk because the cells have got damage. Now, there are many techniques to make them walk. Now, of course, they are very expensive in India. Abhi available nahi hai, but there's something called a body suit. It is called Rewalk, where they put a suit on the leg and it's got a motor. At least the child starts to stand and walk. Abhi walking or standing zaruri kyun hai bacche ke liye? Because if they don't stand, even their bones will become weak and they will fracture. So I always tell the parents, agar bachcha nahi khada ho sakta, to you make a standing frame, you make a KFO if it's possible, and at least make the child stand what we called as physiological standing. मतलब बच्चे के पैर में उतना वेट जाए दिन में at least 20 से 40 मिनट, क्योंकि वेट बेरिंग से बच्चे की हड्डी में जान आती, वरना 15-16 साल में बोन इतने वीक हो जाएंगे, they will fracture or they will get bone pain. So standing in a child is very important, even if he's a non-stander, just to improve the bone quality and the bone stiffness. So अगर बच्चा नहीं खड़ा हो पाता, she's in the wheelchair, अगर leg में curvature है या bend है, then we correct the leg deformity either by splinting or by surgery, so that we make the child upright. खड़ा होना posture बहुत जरूरी है इन बच्चों में. Any condition, whether it is.
She can stand. I make her stand. She stands.
Make her stand.
Yeah.
Otherwise, of course, I have to see the child. Maybe I have to see the child to see and assess them. कि उसमें what is the reason for the muscle weakness or the non-walking.
Okay. Thank you so much, sir.
Where can they come and see you, sir? आप अभी कहाँ बैठेंगे? Where should they come and see you?
So what they can do is they can, Shobha, you can share my number.
Okay.
And then Abhijit will give them the appointment. If you want to have a clinic in SOPAN Center also, we can have a clinic maybe once in 2-3 months. You can call the children there. If they have a physiotherapist there, then we can see the child with the therapist.
Yes.
And that way it is easy to see them in their own environment in school. So and like I said, now we have a very good gait lab in Mahim. It is being given to us by an NGO from US. So we have a system where if it's subsidized treatment, subsidized analysis can be done based on the ration card they have, so that we can run the lab. But we can get a lot of information now from the lab itself. Plus, if they are with a therapist, they can come with a therapist to the lab, and we do a detailed evaluation both in sitting and standing, and we can get an idea what the child's disability is. So either way they can come and contact me.
Sure. I will give this parent your number, and they will contact and take an appointment with you.
Thank you, Shobha ma'am. Thank you, sir.
There's one more question, I think.
Yes, ma'am. Yes. So, sir, the next question is by Payal. In children with osteogenesis imperfecta with short stature, are there chances of reduced lung function capacity?
Yeah, so depending on what type of OI it is. Now, typically, if the child is having multiple fractures or the child is not standing, so mild OI children will usually walk. So mild, which is type 1, they will keep walking. They will not have much problem. So in practice, we see type 3 and type 4. Now, if the child has got a short stature and they start getting fractures before age 5, then it can impact the lung function. See, lung in a child develops by age 5. So if the child has had no problem by age 5, then the lung volume will not change. Unless they get respiratory infection or they have a spine deformity. So I would suggest that if a child is having OI or is having breathlessness or is having difficulty in walking, so most of the children, they don't cooperate for a pulmonary function test, but we give them a simple balloon and we measure what is called the expiratory force of a child, whether he can blow properly. And if the child cannot blow properly, we tell the tell the parents, you teach the lung exercises. So blowing a whistle, simple exercise to expand the lung. The lung function in a child in OI will get impacted if the deformities are very, very severe. That means they get fractures of both the hand and the leg before age 5. And child is not standing. Then they will have some compromised lung function. But the lung volume is good. So lung function may be impacted, but the volume is good. So one can work on the lung expansion by doing lung exercises. OI doesn't affect the lung as such, unless their child is very. So some type OI type 2 which are very, very severe, or type 10A which are very recessive, those children can have lung function problem because they get multiple rib fractures. That can cause it. So every child with OI will not have lung disorder. So that will be my question, unless again, I must see the child with the X-ray, but less than 5 years, if no fracture, lung volume is normal. It will be less than 5 years.
Okay, sir. Thank you. And if anybody else has any questions, please unmute yourself and ask.
So, I've covered a lot of conditions very quickly. I think there may be a few I must have missed, and it may be that if they have any questions, then they can always put out on my email also later on.
Yes, of course. I think questions are not coming right now. So Sheena, please give the thank you note. So.
Thank you, sir, for this enlightening and educational presentation. We appreciate you taking time out from your busy schedule, and also the very interesting measures and aspects that you have discussed with us have made us much wiser and knowledgeable. Thank you from the entire SOPAN team, sir.
Thank you very much. And we hope to be in touch, and I'm sure we can have one combined clinic at some point.
Yes.
So that we can have a more detailed information sharing as well. Thank you very much. Thanks.
Yes. Thank you. Okay. Bye.
Bye.